Two things that are important to remember: that when we have older adults that have decreased cognition or vision changes, these will increase the risk of falls, especially for people that are living in institutions that have these disorders. It will increase the risk of falls within the institutions. So what happens when we have a fall injury? It makes it hard to get around, and it makes it difficult for people to resume independent living. Injuries themselves from falls can increase the risk of early death. And people 75 and older who fall are more likely to be admitted to a long-term care facility. There's also something called a fear of falling cycle. And the fear of falling itself may lead to the increased risk of falling. So when older adults are fearful of falling and they perceive that they may fall, this sets them up to limit their physical activity. It leads them to decreased mobility, and that in turn leads to decreased strength, flexibility, and balance and physical fitness. This also leads to social isolation, depression, and anxiety. And all of these increase their actual risk of falling, whether they have fallen or not. So the fear of falling cycle is prevalent, and it's something that healthcare practitioners and family members can help break that cycle. That's a role that we can play. So what are the signs to look for that an individual may have an increased chance of falling? For a family member or a healthcare worker or somebody working with an older adult, looking at an individual who may need to push up with his hands to rise from a chair, you may notice somebody who has a difficult time stepping up onto a curb. This could be a sign of leg weakness. An individual that may hold on to another person when they're walking or ask for another person's assistance to take their arm to help them steady themselves. You may notice somebody that holds onto furniture as they walk across the room when they're navigating for the fear of falling. And anybody who's been advised to use some sort of a mobility device like a cane or a walker probably has a risk of falling already, because they had already been issued this sort of device for probably problems with leg weakness or balance. Something else to look at are older individuals who take sleep medication because they have difficulty sleeping, or they need to rush to the toilet, especially at night. When they get out of bed and they move quickly, the person may suffer from low blood pressure when they get to rise too quickly. They may fall. A person who is taking sleep medication may have some sort of disorientation if they get up too quickly. And medication may also cause lightheadedness or dizziness when the person goes from sit to stand. So those are things to be aware of. Another thing to be aware of is a client or individual in your household who has numbness in their feet. This leads to difficulty with them having awareness of where their feet are in space when they're walking. And again, anybody who is worried about falling or has fallen in the past may be at risk for falling again. So, what is the key? The key is prevention at all levels. The key is prevention within the home, within the individual's home. It's prevention within the community with the healthcare practitioner, the physician, healthcare workers, physiotherapists, anybody who's working with the older adult. There's three main keys that we would want to look at, especially starting with vision, is that the person should undergo annual vision assessments and, if possible, treatment for vision difficulties. We also want to educate the person on home safety. We want to educate them about the effects of their medications on low blood pressure and dizziness. And we want to educate them on the importance of exercise, whether they're not exercising now, but to encourage them to become more physically active and exercise. Exercise is to improve their balance, their strength, and their coordination, and especially in their lower extremities. Some of the strategies for individuals and their families might be something like a buddy system, where the individual has a family member who calls, or a friend who calls them daily or texts them daily to check in and make sure that they're okay, or just stops by. It's important also for the person to get information from the community from their healthcare provider or another worker that can give them information about fall care prevention programs and risks of falling within the home. It's also important for the person to speak to somebody, whether it's a doctor or a pharmacist, about the side effects of their medications, whether they be prescribed medications or over-the-counter medications, and as well as a hearing check. We spoke of vision exam, but a hearing check is also important. There are some fall detection solutions that are available. One of them is that if the person is using some sort of a smartphone and they have Siri on their phone, if the person falls and they have their phone with them and their phone is within earshot, they can ask Siri to call for help and Siri can contact dispatch for them. There's also something called Ask My Buddy, and this is an app from Google Home or on Amazon Echo. And what this is, the person can put in the information of who they would like contacted. So if an individual does call, someone in their family, a family member or a friend, will get a text that asks them to call dispatch for this individual that has fallen. And there's another form of technology, which is the passive home monitoring system by Samsung, which is called Smart Things. And there's a hub that the person can sign on to, and by doing so, they can start buying then additions to that. And one of them is a door sensor. So what it would do is it would sense that if a person hasn't opened their medicine cabinet that day, and you know that that's where they store their medicines, or their bathroom door hasn't been opened that day, that sends an alert to a family member that perhaps an elderly individual has fallen because they're not getting their medications or going into the bathroom. So there are door sensors that can be placed on doors within an elderly person's home that will alert a family member that perhaps something may have happened. So what's important about regular physical activity is to encourage the elderly individual to keep moving, and if they're not moving, is to begin a program of physical activity. Also determine a plan that fits best with the person's interest and their needs. And some of the best programs are programs that work on balance. For example, Tai Chi programs. Group programs are especially beneficial to older adults where they can work in groups with other individuals and share stories and work on goals with each other. Something else that is very important is making sure that the home is safe. Simple assessments in the home are like installing raised toilet frames and grab bars in the bathroom, putting a baby gate at the stairway, at the top of the stairways if you're concerned that the elderly individual might fall down the stair. Teaching an elderly individual, especially at the level of the therapist, to get up off the floor should they fall, because once a person falls, there's an increased likelihood that they might go into a long-term care facility if they remain on the floor too long after the fall. So it's very important to teach the program with the person within your program prior to going home that if you should fall, this is the correct way to get up off the floor again. As well as just going through some simple checklists within the home and making sure that their home is safe. Another thing outside from the home is making sure that they're wearing proper clothing, that their shoes are the proper shoes, that they're not tripping over their shoes or their clothing as well, that maybe perhaps after they lost some weight, their clothing becomes too large for them and baggy, and there's a risk for them for tripping and falling on their clothing. So there are several things that you could look at within the home to ensure that the home is safe, as well as the person is able to get up off the floor and that their clothing that they're wearing is safe. Within the community, there are 3 steps that are important to starting community prevention programs for falls. Education and training are very important. That's to get people on board that are interested in productive aging, that are interested in helping elderly individuals in preventing falls, and finding likewise individuals to form a coalition for fall prevention. So in Virginia, where I'm from, we have a fall prevention coalition. I was originally from Florida. We had a very large fall prevention coalition of individuals from all disciplines where we help the elderly individuals in our community through different types of programming. Developing policies is also very important, and then designing community-based programs. There are many community-based programs that are very easy to implement, at the community level, within hospitals, within physician offices and clinics. There's training available. Many of these programs have online training or different training sites that you can go to, but some of them offer online training and online certification, and they take you through step-by-step how to develop a community-based program for fall prevention, how to implement the programs, how to recruit people through the doctor's offices and other means through different types of agencies. So in conclusion, older adults are at risk of falling. Vision, again, is very important to check. Exercise is extremely important, and home modification and prevention are key. Remember that a fear of falling does increase the risk of falling, and that engaging in physical activities may prevent falls. So thank you again, everybody, and really appreciate this opportunity to be here and speak with you this at this conference this weekend. Thank you.
Thank you, Dr. Judith.
Thank you.
You've been really on time. I love this.
Okay.
Our next speaker, Dr. Samuel McLean, who is an emergency medicine physician and Jeffrey Output Distinguished Investigator Award at the University of North Carolina, where he directs an institute for trauma recovery. He has developed and leads several national research networks dedicated to improving the mental and physical recovery of trauma survivors. He will talk today about the Aurora study achieving breakthrough to improve physical and mental health outcome after trauma. Welcome, Dr. Samuel.
Thank you so much. It's a pleasure to be here today. I am truly honored to be at this conference, and I'm really grateful for the tremendous hospitality that I've experienced and the chance to visit your beautiful country. So thank you so much. I'm going to be trying to share 5 key points or 5 key messages today. Those messages are that the way that us humans are wired, when we're confronted by a life-threatening situation, changes in our brain dramatically alter how we think and how we feel. That fact, the fact that the brain is so changeable in response to stress, is a tremendous asset to us and has helped us to survive and helps humans to survive very life-threatening events. However, that very same changeability of the brain to stress, the fact that the brain is so affected by stress and changes so dramatically, also creates a lot of vulnerability to disability. And that brain-related disability after life-threatening events, after very stressful events, is common. I'm currently working on a study called the Aurora study with many collaborators and funded by One Mind, and Garen Staglin is here, who leads One Mind, as well as the National Institutes of Health. It's a $40 million study which seeks to develop tools and interventions to prevent brain-related trauma, brain-related adverse disability after trauma. And I do believe that the kingdom is positioned to potentially become the first country in the world to develop and implement universal screening and intervention for its trauma survivors. So I'm going to go through these points one by one. When confronted by a life threat, changes in the brain dramatically alter how we think and feel. The brain, there's nothing more important in terms of the way that our brains are designed that we're able to survive a very life-threatening event. This is a photo that was taken recently of a gentleman who happened to be being chased by a hippo in Africa. So you know that at that moment he's had, and you could imagine that if a lion suddenly appeared at the door, our bodies and our physiology and our brains would change in a host of ways. So what does the brain change? What are some examples of how the brain changes in response to a life-threatening event? What are some of the immediate changes in the brain? Well, the brain causes us to have much reduced anxiety when we're exposed to an immediate life-threatening event. For example, there are a huge part of that initial rush that one experiences, or that initial stress response, involves the release of morphine-like or opioid-like molecules in our brain. There's a tremendous release of opioids in the brain when we're first exposed to a stressful event. Those opioids are initially very anxiety-reducing. If you're too paralyzed to run or get away, that is not an advantage. And so the brain is designed to do that. We're also designed, I think, as many of us are familiar with, to, during a very stressful event or during a life-threatening event, to have great reductions in pain and pain sensitivity. So during a stressful event, there's a great reduction in our bodies in how we feel pain and how sensitive we are to pain. We become much less sensitive to pain. And there's also that adrenaline rush, as we say in the West. There's that immediate, I'm sure we've all experienced it, that you're suddenly wide awake appearing. Like when you think that you're going to get in a car accident and the car just gets away, but there's that moment that you think, or when you have some other life experience. And so you can be, have missed a night's sleep, you could be very drowsy, but when you're suddenly exposed to something that is potentially life-threatening, we experience this tremendous arousal, and that arousal system of the brain really kicks in. So suddenly we're on knife's edge. So those are the immediate changes. They occur instantly when we're exposed to a life-threatening event. So what changes afterwards? So our brains are designed to help us to survive life threats by changing dramatically. They change dramatically initially, and then they cause subsequent changes. The changes that happen in the hours to days after we're exposed to a life-threatening event are very different and often completely opposite to the effects that our brain, the brain changes cause in the immediate aftermath of a traumatic event. So in the immediate aftermath of a traumatic event, for example, or after a traumatic event, one thing that happens is that we are wired to never ever forget that event. So normally, I can tell you that everyone in America who is in the third grade or fourth grade or older in 2001 knows where they were and what they were doing when the Twin Towers were hit on September 11th. And so I am sure that there are events also in your country. I know maybe when, for some of you who are older, than when there was the terrible event when the extremists took over the Mecca, I believe that there was maybe there are certain events that you just, whatever in your life, you can remember exactly every detail of that event. And that's an example of how our brains are designed. It's very important for all of our ancestors to remember where they were when they saw that lion, or where they were when they saw that threat, so you don't go that way again. So we're wired to have profound memory. We're also all designed, our brains are designed so that in the hours and days after a stressful event, a very life-threatening event, we are very anxious, and we're very much on edge, and our sleep is disrupted. Because if you've had something, you could imagine an animal, if there is a fox that has chased a rabbit and the rabbit's gotten away, the rabbit better remember, better stay on edge and alert for that fox for the coming hours to days to help it to survive. So we're all wired to be anxious after a stressful event, to have decreased sleep. And we're wired to have increased pain. So I think it's commonly understood that people have reduced pain and reduced pain sensitivity during a very stressful event when they feel their life is threatened. I think it's much less understood that in the days and weeks after such events, pain sensitivity really increases. So things that weren't painful to people now become painful. Their body's sensitivity to pain has changed. And so people start to report many new pain symptoms often in our trauma survivors. And similarly, just like an animal that experiences a very stressful or life-threatening event knows to then go under maybe it's injured during the event, the body's wired such that the animal withdraws, goes under a bush, rests, tries to take it easy and get better. But that sort of withdraw from activities, those changes in the brain that cause us to not want to be around other people, to withdraw, to be by ourselves, those kick in, and those can cause, those are adaptive in the setting of you've just experienced a life-threatening event. But this design of our brains to so dramatically change its function in response to stress helped our ancestors survive countless life or death situations. You're each here today because over all of the generations before you and all the stressful and life-threatening events that your ancestors experienced, they were able to get away and they were able to survive because our brain changes so dramatically to help us to do that. However, this extreme changes in the wiring of our brain and how our brain functions, these extreme changes in response to stressful events also create vulnerabilities. And these vulnerabilities result in a tremendous global burden of disability today. So what kinds of disabilities? The brain is designed to really change how it processes memory in response to life-threatening events. And that's good in that it helps us remember these types of events. But in some individuals who have experienced a traumatic event, they have disordered memories. They have difficulty remembering things. They start to have flashbacks of the event where the memory suddenly comes to mind, and it's suddenly as if they're being exposed to that terrible moment all over again and again, and that happens out of the blue. Or they develop, because of these terrifying symptoms, a lot of avoidance, where they stop going out, they stop being around anything that they think might trigger that sudden re-experiencing of the event, just like it might happen again. That's memory becomes, the wiring of the memory part of the brain develops problems that lead to disability. Similarly, it's very good to be on edge and be ready for anything during a life-threatening event. But if you always feel on edge and always feel like your life is in the balance, that you're always so wound up, then that's very, very difficult. It's a very difficult experience. And many of our war veterans, for example, in the United States, they feel like always, they tell me, years after coming back home, even if they're sitting on the couch in their house, it's just like they were about to go around the corner of a street or whatever, because they just have that sense of arousal is still on. And we see that with war veterans around the globe, or people who've been experiencing traumatic events around the globe. Or sometimes people develop numbing symptoms. They feel very cut off from others. Pain is a huge problem in trauma survivors, whether you're talking about sexual assault survivors, war veterans, car crash survivors. It's a tremendous global problem that results in so much lost work and disability. And things like depression. Depression is just as common as post-traumatic stress. It happens often after stressful and traumatic events. We know that a profoundly stressful event is a trigger for depression and is the most common trigger of depression among all triggers. So this kind of brain-related disability, unfortunately, the kind of adverse problems that can develop is not rare. In fact, it's very common. If we look at some of the numbers, they're really staggering. So 8% of men around the globe will be in a combat situation sometime during their lives, will be in a wartime experiencing combat. We know that 40% of men who experience combat and experience war will develop post-traumatic stress. 30% will develop depression, and these are sort of our best international estimates based on the published data. 25% will develop chronic pain, and many more will develop a lot of symptoms with lightheadedness, dizziness, taking longer to think, cognitive dysfunction that is often termed post-concussive syndrome. Similarly, we know that 9% of women or 9% of men will be physically assaulted. Almost 1 in 5 women around the world are sexually assaulted at some point during their lives, and there are 60 million car crashes a year. All of these events, unfortunately, the data indicates that these types of outcomes are happening roughly on average sort of 2 to 3 out of 10 of every one of these individuals, every 10 individuals that have these types of events. We also have international published rates that aren't by category of the trauma that happens, but just if you take all people who've experienced a traumatic event, a life-threatening event, and who come for care, among those who are admitted to the hospital and among those discharged to home after coming to the hospital for care after trauma, both among those who are discharged to home and those who are kept in the hospital, these outcomes are very common. They're equally common in both groups, which is surprising, but it's because these effects are caused by the life stress and not by the stress of the event much more than the physical trauma. It's interesting that one can take rates, so based on 2012 Ministry of Health published data, it looks like there's about 3 million people who come to the emergency department every year in the kingdom. That's probably a little bit of an underestimate now because we're 2018, but in 2012 those were the numbers. So based on international published rates that I just showed you, that would translate to about every year 700,000 new cases of post-traumatic stress in the kingdom, and about the same number of people with depression, new onset depression, among trauma survivors in the kingdom, and almost 1 million individuals in the kingdom with new onset musculoskeletal pain. And again, those are estimates based on international studies of people, what happens to people after they have a traumatic event and come to the hospital for care. So 100 to 150 years ago, in terms of where we were with trauma care, we felt that an infection was inevitable. If you had a serious injury like this Civil War person from the United States from our Civil War in the 1860s, and you had amputations, for example, that half of people who had a limb amputated would get infected in the early aftermath of surgery. They would develop a lot of pus, a lot of infection. Many would die from that infection, and but that was thought to be just inevitable consequence of having surgery in the West in the 1700s and 1800s. Now we've learned that infection like that is completely preventable. And so it's really shifted from understanding that that's inevitable to understanding that that's preventable. And now, because of interventions that we have, infection is very rare. And so we need to do the same thing with brain-related disability. Rather than thinking, oh, you know, if a woman is sexually assaulted, then 50% or more of women will have post-traumatic stress for at least a year, oftentimes many years, disabling, or a third of car crash survivors are going to get post-traumatic stress. There's nothing that we can do about it. That's the exact same attitude that we had towards infection, and it's really, we can do a lot better. So the Aurora study seeks to develop tools and interventions to prevent brain-related disability after trauma. That's this large study being run in the United States, 5,000 individuals who experience trauma. We enroll people who come to the emergency department, or we enroll people also who are informed of the sudden death of a loved one. I'm sorry to tell you this, but your husband was just killed in a car accident, or your wife was just killed in a car accident. What happens to these people? We know the rates of disability are very high. And the Aurora study, we follow these people over time using a whole multimodal range of assessments. So we have a collaboration or partnership with Google. Google provides watches, their research watch, to us, to all the participants. We use a research watch. We use an app based on their smartphone to understand how the words and language people use change, how their mobility changes. We can assess through GPS, blood for genomics, really to get a very complete picture of these adverse brain outcomes, to develop screening tools that we can use at the time of trauma to identify people who are at high risk of these adverse outcomes, and then to test and begin to test interventions that we can use to prevent these adverse outcomes so that we can prevent post-traumatic stress, prevent depression, prevent cognitive dysfunction and pain. And so that's what we're in the middle of right now. Our goal is with each of the different adverse outcomes people to develop, that we get a very rich and deep understanding of that outcome. And again, that we translate that into identifying initial biomarkers that predict adverse outcomes. Those biomarkers or predictors could be a brief survey, it could be a blood test, and that we develop understanding of the course, understanding better diagnostics, and most importantly, of course, targets for intervention so that we can do better on preventing this. The study also, we break down the old silos. Unfortunately today, one group of doctors studies post-traumatic stress and a separate group studies each of these other outcomes. We are looking at them all together because there's one brain, one mind that produces all these different outcomes. And so that's where we are. We're at about 30 sites around the U.S. I do believe that the kingdom, just in closing, there's exciting opportunities for you all to do similar types of research for the folks in your country. And I think that there's exciting potential because you have a tremendous commitment to leadership, as we saw amazingly this morning, to disabled and to the people, those of us in life who've experienced unfortunate events. You have the resources with this tremendous center and the will, and you have a commitment to becoming pioneers in science and technology. So I think there really would be the potential to develop the kingdom as actually the first country in the world to be able to universally screen and develop interventions. I am grateful for your time today, and again, it's been a real honor and pleasure to have a chance to come to your country and enjoy your tremendous hospitality and meet so many wonderful people. So thank you so much.
Thank you, Doctor. We really enjoy it, and I've been reviewing my mental status. Our next speaker is Dr. Ahmed Al-Habtar, who is a fellowship of Australian Faculty of Rehabilitation Medicine. He's a spinal cord injury medicine fellowship also from Australia, and he was a consultant physiatrist and spinal cord injury medicine at King Fahd Medical City from 2014 up to 2017. Currently, he is a consultant rehabilitation medicine at King Faisal Medical City in Asir, and he is also a member of Physical Medicine and Rehabilitation Scientific Committee at Health Specialties. He will talk today about the predictor of physical activity limitation in community dueling older Australian men, prospective cohort study. Welcome, Dr. Ahmed.
Thank you very much. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين. Today I'm going to present the results of a cohort study that I was involved in, and really presenting these figures after your presentation, Dr. McLean, is like seeing a drama movie after a science fiction. So but hopefully you will enjoy it. Nothing to disclose. Acknowledgement, I have received a sponsorship from King Salman Center for Disability Research. So the King Salman Center sponsored the PI, or the primary investigator, that is me. Dr. Daniela has done the calculation for the drug burden index, and we'll talk about that in a moment. Dr. Karen Beth is biostatistician at Westmead Hospital, Sydney, provided statistical support. CHAMP project received funding from National Health and Medical Research Council of Australia. Authorship, the primary investigator is myself. Ian Cameron is a professor of rehab medicine, University of Sydney. Bob Cumming is also a professor of public health in University of Sydney. The rest of the CHAMP co-authors are yet to be approved, as we need to follow the guidelines of the International Committee of Medical Journal Editors. I thought I would just talk briefly about the ICF model, because it is relevant to this study, and I'm not sure about the background knowledge among the audience. So the International Classification of Functioning and Disability, or the ICF, was approved by the WHO in 2001. It is one of the family of classifications similar to the ICD-10, but this focuses on function and disability. The common misconception about this classification is a lot of people, they think or they perceive ICF as a disability tool. It's more of a functional tool. Even normal people can have ICF classification. It's just a framework of function, so you can use it as a tool to guide your approach to your patients, but I don't recommend using it to code your patients. Activity limitation are difficulties an individual may have in executing activities. The definition or the taxonomy are fairly important, not only at your personal level, but also for my study today. Activity is execution of a task. Participation is the activity in a life situation. Activity limitation is if you have a problem with the activity. Participation restriction is if you have a problem with the participation. It's fairly academic. Some people, they find it boring. I find it interesting. This is a scanned copy of the ICF WHO book. Not sure if it is clear to you, but the ICF effectively is, or essentially is divided into two parts. One is about function and disability. I'm not sure if you can see Anyway, in the left side, there is the function and disability part. The right side is contextual factors. Each one of them is divided or subdivided into components and domains. So under the function and disability, there is the body structures and body function, and also the participation and activity. Any problem with activity and participation will lead to activity limitation or participation restriction. Any problem with body structures and function will lead to impairment. Both are called disability. So disability is a broad term divided into or involve all these aspects. I'll give you an example to illustrate more. So body structure, the example is a spinal cord injury patient. A body structure is the muscle, skeletal muscle of the lower limbs. Body function is voluntary muscle movement of the lower limbs. The activity is executing or walking, regardless of the situation. Just walking is an activity. If you have a problem with comfortable footwear and then using their walking aids, the average time of 2 trials were used to calculate the speed. And we've used 0.8 meter per second as the cutoff for slow walking. And we've done that because it has been reported any one who walks below this is considered to be abnormally slow. The 5-time repeated chair stand, participants were told to cross their arms, cross their chest to avoid using them. Whilst seated, the participants were asked to stand 5 times. The time then calculated or measured. And then whoever was able to complete the task without using the arms and not within the lowest quartile was considered normal. Otherwise, activity limitation is deemed present. This is only to show you how do our outcome measures fit with the ICF model. So each one of them has a match in the ICF model and coding system. We've already talked about our outcome measures. The ADL is binary. Walking speed as an outcome is a continuous variable, but when we use it as an explanatory variable, we've used it as a binary as well, and you will see that. 5 times chair stand was a binary variable as well. And then the explanatory variables, we've included about 22 explanatory variables that either we've hypothesized that they might impact on function, or they have been reported in the literature that they do predict and they do have some association with disability in general. So a big list of things, including demographics, age, level of education, marital status, living arrangement, language, country of birth, etc., plus measurement of physical and mental ability and social aspects of life, including social interaction and drug and smoking history. I'm repeating, we've used measures or scales with evidence-based, approved, good psychometric attributes. The explanatory variables, not going to go through all of them, only to highlight on few of them. So they're self-explanatory. For example, comorbidities we've decided to use 4 as the cutoff for the number of comorbidities, only because it has been commonly used in the literature. This is also the case for polypharmacy. 4 drugs were used as the cutoff. DBI, or the Drug Burden Index, is a special method of measuring the quality of the consumed medications, because often the literature report polypharmacy, and polypharmacy is all about quantity of medications. This is about the quality. So medications that has sedative effects or anticholinergic effects were found to put an impact on function, disability, and also associated with falls and fractures. So that's why we thought it is worthwhile not only to include the number of medications or polypharmacy, more so we would like also to explore the DBI and the content of medications themselves. Dementia, one of the strengths of this study is not only we've used or relied on mini mental state examination, but we have also, so anyone who scored 26 points in mini mental state examination would need to go for a proper neuropsychological assessment, geriatrician assessment, and then a panel of 3 geriatricians, 1 neuropsychologist would diagnose either with dementia or mild cognitive impairment. This is one of the strengths of this study. Analysis, we've used the IBM SPSS statistic 22. We ran a correlation matrix trying to determine if there is any unexpected or exceptional kind of correlation, and then we ran a univariate regression analysis for each one of the outcome measures, followed by a multivariate regression. And then 99%, it is worth mentioning this, 99 participants of our population have died during those 2 years, and also 50 have moved out of area or moved to or admitted to an aged care facility. These numbers were excluded as part of our missing data. The results, this is the baseline attributes of our study. The majority of our sample were under 75, nothing really standing out to be odd or exceptional. So living arrangement, majority of them, they married and living with someone at home. Good number of them have or received good education. English, being Australia, the study was in Australia, English was the main language of or at home. Country of birth also, Australia, is almost 50% of them were born in Australia. Social satisfaction, interaction were also reasonably high. And so just nothing really to was really outstanding or considered to be an outlier. So baseline attributes were fairly expected and consistent with the Australian census. ADL, or the activity limitation in the beginning, so only 8% at the beginning, only 8% of the population had activity limitation in ADL. About 31% of them had activity limitation in sitting and standing, and also 34% were or had activity limitation in walking speed. Just trying to match and benchmark to determine if our results are consistent with the Australian population. It's fairly similar except the country of birth and language. And according to the council of these geographical areas, majority of the population in these areas were born in Italy, Mediterranean in general, Italy, Greece, and Lebanon. So that was justifiable, and we were able to explain it. Education, it's fairly consistent with the Australian census. And the disability, the Australian census does not really specify what kind of disability. It's a crude kind of assessment, so we could not really use it as an accurate tool to benchmark. Despite that, it's not, there is no significant heterogeneity. We ran a correlation matrix. Nothing stood out to be very, very significant. Things that we expected, for example, alcohol was associated with smoking. Depression was associated with social interaction, satisfaction, anxiety, and using psychotropic medication. So in our correlation matrix, none of our explanatory variables was correlated or related or associated with any other variable other than what we expected, or at least we're able to justify. The results, or the analysis, we've excluded anyone who had activity limitation and ADL in the beginning, and then we ran a univariate analysis after 2 years of assessment, and then multivariate according to their p-value, or the significance of association, and we've ended up with this busy table. And from this is the univariate assessment. On the left side, I know you cannot see it, but on the left side is the baseline, and the right side is the 2 years. Not very important in terms of the ultimate results. And these are the variables that were associated significantly or correlated with the ADL limitation. And then we ran the ultimate binary logistic model with backward elimination method, and we've ended up with 6 variables associated or maybe predicting or could predict disability in ADL after 6 years. That's the age, advanced in age, level of education, polypharmacy, walking speed, cognition, and the physical component of short form 12. These are the variables that were included in the model, but the research team have decided to include the grip strength and vision, as we have hypothesized that they might be impacting or affecting the functionability for ADL. Similar kind of assessment or analysis was done for the 5 times chair stand, and then we ended up with almost all variables associated with it. But what variables might predict activity limitation after 2 years in 5 time chair stands, also age, level of education, DBI, walking speed, grip strength, and PCS, or the physical component of the short form self-reported health. These are the variables that we've included. Walking speed as an outcome variable, as I said, was considered as an continuous variable. Similar kind of investigation. The only difference is multiple regression. I'll wrap up soon. Multiple regression was done. We've ended up with similar results. Almost all variables were associated. And then this is the literature review, just trying to see if there is any similarity in the literature. So the age has been found to be associated with functional decline and sarcopenia. High level of education positively affects health and functionability. Elderly depression can lead to disability. BMI is also associated with disability. Decline in walking speed can also impact, and comorbidities associated with progressive decline in function. Social support also affect function. So this is the literature review, and these are our results, fairly consistent with the literature. Only very few significant variations. One of these, or some of these interesting points, is BMI, alcohol consumption, and vision were not associated with activity limitation in ADL. The PCS, or physical component of short form 12, predicts activity limitation in mobility and self-care, which is very interesting. So one of the explanations that we thought about it could be the 0.8 being the cutoff of abnormal slowness. Maybe is inaccurate, and it has been, unfortunately, used in the literature quite a lot. Grip strength is not associated with decline in walking speed, despite being frequently reported in the literature. Falls might predict slowness in walking. Subtle change in walking speed might be an intrinsic factor that leads to falls. And we could not determine how could spoken language at home predict decline in walking speed. And compared to chair stands and walking speed, ADL needs sound executive function. So that's why we believe cognitive function has helped us predicting the disability in ADL. Clinical implications, which is my last slide, early detection and identification of falls risk might prevent activity limitation. Screening of geriatric depression not only going to improve mental health, but also physical well-being. Careful monitoring of patients who take multiple medications, particularly psychotropic, and discontinue unnecessary medications. Simple clinic exams such as grip strength and walking speed might help predicting disability in the future. And also the limitation of this study, missing data of a lot of participants. And also, although the objective of CHAMP study is to investigate men, it would have been great if we were able to compare the gender impact on function. Sorry to take more than what's designed, but thank you very much for that.
Thank you, Dr. Ahmed. Our next speaker, she's hiding down there, and she come now. And she's so special for us because 12 years back, Dr. Saluji, she came to Saudi and she introduced and do the NDT Bobath course in King Fahd Medical City, which was the first time in the country. Dr. Gillian Saluji is a pediatric physiotherapist with a special interest in working with the family and children with cerebral palsy, living in a resources-constrained African setting. She is currently the executive director of Malmon Onward, a nonprofit organization providing therapy services and caregiver training to children with cerebral palsy living in a poor rural area of South Africa. Gillian obtained her PhD from the University from South Africa in 2007, where her thesis focused on children with CP and their family. She's actively involved in several research projects regarding children with cerebral palsy, and her topic today that she will share it with us is the evidence for hand-on therapy for children with cerebral palsy, result from 2 South African studies. Welcome, Dr. Gillian.
Dr. Sham, thank you very much for the invitation to come and present here. It's really good to be back, really good to be back in this country and to see all the changes that have happened. And I'd also just like to congratulate you and your team on the amazing conference, an amazing hospitality, and also the wide selection of papers, topics that you have got here. I've certainly learned so much already on things beyond cerebral palsy and beyond pediatrics. I would just be interested in knowing, in the audience here, how many of you are therapists working with children with CP? Oh, good, 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 good. The big question that all therapists have working with children with CP is, what constitutes best practice? There are so many different ideas out there of what we should be doing, and it's really hard to find the evidence for it. And in particular, the evidence for direct hands-on therapy. A little bit about my background or where this comes from. As Dr. Sham said, I work at the organization called Malamulele Onward, and we're a team of people looking, therapists and supporters, family members, who are looking for solutions in how we can improve the quality of life of children in deep rural areas who have CP whilst we equip their families for a lifetime of caring. So that is the background to the work that's behind the study. A couple of things that also informed this particular study is firstly that it's hard to find the evidence for what we do as therapists. Therapists, we love working with our hands, and it's really hard to try and find out if what we do is evidence-based, and if you don't do evidence-based work, it's really hard to get any funding or support for it. The reality is that in remote rural areas of South Africa, and I'm sure pretty much southern African countries, is that children have very little access to therapy. So huge therapy needs very few staff. So in this setting, is there actually a role for hands-on therapy? The context and the background of the people that I work with. On average, children in rural parts of South Africa who are dependent on the public service for therapy receive probably not more than 35 hours of therapy over their lifetime. And therapy is usually passive movements, up and down like this, and following a developmental sequence. So there's a question as to how effective these 35 hours of therapy actually are. Families are usually single-parent families, female-headed households, mothers and grandmothers, incredibly high levels of poverty and employment, and coupled with that, very low expectations of children with disabilities. So the aim of this particular study was to investigate the effects of a focused, once-off therapy intervention model in the functional performance of CP. Put it another way, we wanted to, the model of trying to get therapy to children in remote areas was to say, could you give them a short block of intensive therapy? So I conducted 2 studies, and I'm actually combining them in this presentation today because the one actually is a natural follow-on from the other. South Africa is at the bottom end of Africa, where the 2 red stars are, tell you where the studies were conducted. Very deeply rural areas characterized by great distances and not very many, not easily accessible to get to all the children's houses. So the first study was a case control study done in the northern part of the country, and the second study was a randomized control study. The outcome measures that were used, the assessments were done, it was a repeated measures design, assessments done at baseline, immediately before the intervention, immediately afterwards, 2 months later, and all done by trained interviewers. And there were outcome measures relating both to the child and the caregiver, and I'm only going to be commenting on the child-related outcomes in today's presentation. The two main outcome measures are the gold standards for working with children with cerebral palsy, which is the gross motor function measure, and a modified version, the PEDI, and why it had to be modified. We had to make it suitable for an African setting. And then parent photographs and a parent questionnaire. So what did we do? The first study, which is the case control study, there were 20 children who had moderate to severe degrees of CP, who got 5 days of intervention at one hospital. And those children were matched for the age and their GMFCS, which is the level of functional abilities. They were matched with 19 children at a second hospital in the same district. And so all children continued their usual 45 minutes. So the one advantage of working in resource-constrained settings is that because children get very little access to therapy, it does make it easier to try and study how effective therapy can be. In the second study, we had 105 children, all from the same hospital, and they were placed in one of 3 groups, depending on where they stayed, and then each group was allocated to one of the 3 intervention arms. And all the children in both studies continued with their once-a-month sessions at the hospital. So, what did the study actually do? They were similar. The intervention group in the first study had 5 days of hands-on therapy from a group of therapists who volunteered their time, physios, OT, speech therapists. The children received 75 minutes of therapy daily for 5 days, and caregivers were trained in how to carry the program on at home. And in the second study, the children were divided into 3 groups. The first group had no hands-on therapy. The children just received, the parents received training from another parent through our Carer to Carer program, and each workshop was 2.5 hours long. So it was a parent training intervention. The second group had theoretically no intervention other than their monthly therapy sessions at the hospital. And the third group were the ones that had the therapy. So they had 5 consecutive days of hands-on therapy, 75 minutes a day, for 5 days, and then they also got an hour of parent training. So the intervention groups, Group 1 and Group 3, had the same amount of intervention, which was 2.5 hours. All children in the study got equipment, appropriate devices, and parents were trained. So if you want to see what that actually looked like, here some pictures are from the study. We had a group of altogether about 20 volunteer therapists. All were Bobath trained and delivered therapy for an hour, 75 minutes per day, per child for 5 days. Okay, so it was a very busy period, 5 consecutive days. The children came in each day. So they got therapy. Then the Carer to Carer training was done by a parent herself that we had trained to do particular workshops, 5 workshops for other parents on aspects of cerebral palsy and how best to help their child at home. Okay, so those are the Carer to Carer workshops happening. And it was also experiential training. This was a workshop on eating and drinking. So in addition to the therapy and the training, all parents in both studies had to practice the things that they were taught. Okay. Then equipment. So equipment and assistive devices that may be a given in most countries are certainly not a given in a resource-constrained setting. So children did not have equipment at all. So included in the study, all children, whether they were in the control group or the intervention group, all got equipment. So the equipment and devices were based on the child's needs. All children got a bench to help with dressing and undressing. They received a standing frame if they were able to stand or needed to stand. They received a posture support chair, and they received splints. So there's some equipment. The benches are all locally made equipment, standing frames and posture support chairs, locally made. We made them ourselves, hot splints for the children. We also got equipment donated from the UK. People sent shiploads. There's an organization that sends used equipment over, so we were able to issue the children with donated equipment as well. Okay. Each child got a toy. Most of the toys we had made ourselves, but each child got something that was appropriate. So the child on your left is a child with a hemiplegia, and he's got a tin with pegs in it, and the child on the right has got a visual impairment, so they got a shiny board. Okay. Here some examples of the children all practicing using the equipment. And then at the end of the week, the parents then took all this equipment home, and they were hugely excited by receiving it. Okay, so that was what we did. What were the results? So this is just to tell you how many people were in each study. Each group had about 30 children. The study where we divided the children into 3 groups. There were 31 children in one group, 38, 36, and in the second study, there was an intervention group was 25 and a control group of 20. So altogether, we had over 100 children, different children participating in the study. Not all of them completed all the assessments. It's quite different doing the study when it's quite a long distance from your home base. And the average age of the child was about 5.5. Okay, we tried as best as possible to match the children in terms of the type of CP they had and also in terms of their functional levels. Okay, so this is the main slide of interest, and that is, did it work? So this is the GMFM, which measures changes in gross motor function performance. And I've highlighted the 2 areas in white, which show the difference between before and after. Remember, this intervention only happened over a 5-day period. And what you can see is the groups that had therapy, which is the middle columns, the pink column, hands-on therapy, and the pale gray column. You'll see that those children, their scores improved the most, and I'm delighted to tell you that these scores were significantly improved as well. So we were all very excited to see that. We then followed the children up over a 2-month period and then had a look at what happened 2 months later after they carried on with their usual monthly therapy. And only the scores obviously dropped, but however, the intervention group in the first study were able to maintain the changes made. All right, so that measures gross motor function performance, and the other outcome measure we used was the Pediatric Evaluation of Disability Inventory. And once again, this showed the slide in the middle. If you compare the scores, the changes from when we started the study, the baseline, to the follow-up, which was the last phase of the study, that those children that had received the intervention, their scores improved the most, and it was statistically significant. So those were the 2 outcome measures, the GMFM and the PEDI, objective measures. Then we also asked what the caregivers, if they could perceive changes, if they perceived any changes, and if they could describe them. So every caregiver had to be able to tell us whether or not just, yes, I'm very happy, you gave me some treatment, you gave me some equipment, but actually, did you see any changes? And these were the changes that the parents were able to report, child by child. So here an example, she said she can now make sounds, she can walk with support, she plays with other children, she tries to drink from a cup, and her hips are now straighter. Another carer said he's able to show me some signs, he can chew, he can open his hands. All right. The 4th measure that we used to try and be able to track change, because remember we're working with children with quite severe disabilities, was to able to have a photographic record of before and after. So there you have a child that had spent his day lying in a small little ball, and he then gets placed in a standing frame, and then he's able to be stood between his mother's legs. So that's another way of being, it's difficult to measure, but I think it's a visual confirmation that change was possible. Once again, another child not able to sit at all was able then to sit in a beautiful piece of donated equipment. So, what do we conclude from that? I'm very excited to be able to tell you that in a resource-constrained setting where the children don't get access to regular therapy, is that we were able to show changes definitely in the short term. But however, whether or not you can maintain those changes after 2 months is not clear, and I think it's almost common sense in a way that you can make a lot of change in a short space of time in children that have not had therapy before, but if you want to maintain those changes, the children do need access to ongoing support and care. So, bottom line is that there's clear evidence that hands-on therapy is effective in the short term, both in terms of improving children's gross motor functional skills, as well as some of their daily life skills. So I think the take-home message for therapists is to beware and wary of any approaches and models of care which do not include a direct hands-on component. But alongside that, therapy should never be offered in isolation. You can't just offer hands-on therapy. You need a holistic approach which includes the specific needs of the caregivers through a caregiver training program, specific attention to each child's needs, as well as the provision of the assistive devices. You can't have one without the other. You need therapy, you need the parents to be trained and given information, and you also need the children to be given the equipment that they need. So I thank our funders and sponsors that made this study possible. I thank all the therapists who volunteered their time, and I want to say a special thank you to the King Sultan Center for Disability Research for the opportunity to come and share our experience with a wider audience, and I especially thank you for your attention this afternoon.
Thank you, Dr. Julian. Thank you. Our next speaker is Dr. Taras Volvosh, physician intern, International Clinical of Rehabilitation. He graduated from the Faculty of Medicine he graduated from Faculty of Medicine at the Halachi Leviv National Medical University. I hope I got it right. It's not. From 2007 to 2009, completed his internship in urology and as District Hospital and the Leviv Regional Clinical Hospital. He is a correspondent member of European and Eastern European Academy of Childhood Disability, and he published more than 25 articles, and also I'm glad to see his mentor and his master of technique. It's the Professor Vladimir Kozavkin, who is behind all of this. They will talk today about the influence of the spinal manipulation on muscle spasticity in cerebral palsy randomized control trial. Welcome.
Шановні колеги, мій англійський не дає можливості мені сьогодні тут вас привітати, подякувати за запрошення і поділитися деяким досвідом нашої роботи, яким чином можна суттєво допомогти хворим дітям.
Hello, dear friends. Thanks for invitation here. Unfortunately, my English is bad enough, so I'll speak in Ukrainian, and me, Dr. Taras, I will translate. So the main item today is how to help our kids.
Да. Тому я пропоную, оскільки проблема з часом, приступити до своєї інформації.
So now we'll speak on the spasticity problem exactly.
Okay.
So today our topic is an influence on spinal manipulation, on spasticity and manual dexterity in patients with cerebral palsy. If we speak on where are we from, just few words. We are International Clinic of Rehabilitation coming from Truskovets, from Lviv region in Ukraine. And if you look onto the distribution of medical care needs, the problem of spasticity and long-term rehabilitation takes 90% of all needs in medical care. So only 10% of patients with acute problems like traumatic cases or stroke patients, but mostly that is a necessity in so-called medical rehabilitation. If you look onto the epidemiology of cerebral palsy, we see statistical data that show the prevalence of CP in Ukraine is like 2.4, 2.6, in USA it's 2.0, in England is 2.1, and in Saudi Arabia is 4.1. So this problem is really up to date for Kingdom of Saudi Arabia. And if you look into the diversity of brain lesions, there's more than 400 problems that may cause cerebral palsy. It may be brain maldevelopments, it may be periventricular white matter lesions, it may be cortical and deep grade matter lesions, but all of them, they have a single thing which retards the development of the child. This thing is called vertebral subluxations. Because when we have one of these like 4 and plus 100 brain damages, the single united thing for them is a problem of their spine. That's a problem in spine kinematics, and that's a problem of shaping of so-called vertebral subluxations or fixed areas of the spine. This diminishes movement control. This causes muscle spasticity. This causes joint contractures or secondary joint contractures, and this causes trophic disturbances. So if you look into a Medline search results, there's almost 2 million articles addicted to nervous system diseases. There's more than 14,000 addicted to cerebral palsy. There are some articles addicted to vertebral subluxations. It's 1,300 almost. But there's no combination of this vertebral influence and cerebral palsy. So this means that the spine is really forgotten in these patients. So if you look onto this knowledge, so this knowledge, or just to know that spine exists, is not enough. They should be transformed into an abilities. Abilities should be transformed into an action, and only a repetitive action may give us a result. And this is an ongoing scheme. This means that results should give us a new scientific knowledge, and this scheme repeats. On every pass of this way, motivation is important and getting information. So if we speak on spasticity, this is the most often problem of cerebral palsy kids because it affects about 85% of all cases. The important thing is that it decreases the quality of life, which is the main aim of medical rehabilitation. And this is a motor disorder which is characterized by a velocity-dependent increase in tonic stretch reflex. So it means a greater resistance is felt with faster stretches, a so-called clinical sign of a spastic catch. So muscle spasticity is a clinical syndrome of CP, and its reduction plays a great role and is a great therapeutic target. Spasticity treatment currently may include different options like exercises, casting, taking medications, chemodenervation, like baclofen pumps, selective dorsal rhizotomy, and others. But unfortunately, they have a limited efficiency. So wide range of complementary and alternative therapies should be used or tried to be used. Spasticity as a symptom is a component of upper motor neuron syndrome, and this is caused by a central nervous system lesion. It involves pyramidal and parapyramidal pathways. And if you look onto the upper motor neuron syndrome, we have a group of negative and positive signs. Group of negative signs includes fatigue, loss of dexterity, and weakness. They are responsible for paresis part, and they may not be influenced by short-term rehabilitation. There's a group of positive signs as well, which is spasticity, Babinski sign, increased tendon jerks, muscle spasm, dysenergy. They are responsible for spasticity part, and they may be changed after even a short-term rehabilitation. So on this slide, you see how muscle tone in cerebral palsy kids is changed. Mechanoelastic properties of muscles and connective tissues are really different. And also this is the reason for this tonic stretch reflex increase. The current clinical scales for muscle tone evaluation, maybe you all know them. They are Ashworth scale, modified Ashworth scale, and Tardieu scale. But unfortunately, they may not distinguish between a few components of muscle tension, which are not just spasticity. If you look onto the passive motion, it has a group of components. This means neural components and non-neural components. A neural component is a real spasticity, so it means this tonic stretch reflex. A non-neural component is our inertia of the limb or increased speed according to increased speed of motion. This means elasticity problem. It depends on how much you stretch the muscle. And this a viscoelastic component. This is a muscle fiber friction on the onset of motion. So for distinguishing these components, we used a tool called neuroflexor. It's an instrument to measure spasticity. It measures resistance to passive movements of the hand with a different speed velocity, slow and fast. They use force transducers, which measure the power of resistance during movements. The plus in this device is that we do not need electromyography. The motion is passive, so the component of unbiasedness is excluded, and there's a standardized proceeding. So this device is using for dividing these components, and it gives us a quantitative mark of every of those. And there is a neural component, which is a general resistance minus this elasticity part and minus viscosity. So our research was conducted maybe 15 or 20 years ago, and there was an analysis of almost 11,000 patients done. The decrease of muscle spasticity when we use spinal manipulation happens in 94% of cases. But these studies, currently, they are not evidence-based, and they have methodological limitations. Because spasticity was measured during modified Ashworth scale, which has low validity and low reliability. So currently we made a pilot study with 29 clinical cases. The level of spasticity was measured quantitatively by this device before and after rehabilitation, and also after one spinal manipulation. Patients were with spastic forms of CP, mark scale 1 to 4. So we have seen the decrease in spasticity level by 1.65 newtons after one manipulation, and this study has been published in December volume of Journal of Chiropractic Medicine at the New York Journal in December 2016. This was like a first bird. After we made an extended study to study the influence on spinal manipulation on muscle spasticity and on fine hand functioning in cerebral palsy patients, we made it as a randomized clinical trial. Included 78 children with spastic CP aged from 8 to 18 years and max levels 1 to 3. Experimental group, it was 40 kids, and control group, it was 38 kids. So study design, after first examination, patients were randomly selected to spinal manipulation group or to imitation of spinal manipulation or to a sham manipulation. After the second evaluation has been done for both groups. It was conducted 5 minutes after the intervention. And about examination, we included neurological examination, spasticity measurement using this neuroflexor device, and manual dexterity testing using very simple box and blocks test. This is a test which is used to measure manual dexterity. It determines how many blocks may be transferred from one part of the box to another in 60 seconds. About intervention, we had, as just told, experimental and control group, and there was a spinal manipulation done by Professor Kozavkin method in thoracic, lumbar, and cervical regions of the spine, and control group received a sham spinal manipulation. So about the results achieved for these two randomized control trial groups. There was a decrease of neural component from 5.5 to 3.3 in experimental group, and decrease of neural component from 3.8 to 5.7 in control group. And also we got plus 4 and 1 blocks in 1 minute in experimental groups and plus 3 blocks in a control group. So this means these changes were statistically significant, and what we may conclude that this study showed that spinal manipulation somehow decreases spasticity of forearm muscles in patients with cerebral palsy. This decrease in wrist muscle spasticity was noted even after a single spinal manipulation, and happened a few minutes after this manipulation has been performed. Afterwards, these changes were potentiated by using other treatment modalities like physical therapy, stretchings, using another ways of physical activities and physical influences. This reduction of spasticity is not studied enough, these mechanisms of the phenomenon, and still further research is needed. So currently we got an approval on publishing this paper in the same Journal of Chiropractic Medicine of New York, and hope to proceed with longer-term studies to study long-term effects and to see what is the pathophysiology of influence of these spinal manipulations. Thank you for attention. Thanks for your time. Thanks to organizing committee for inviting us here. Really nice conference, and we are very pleased by your hospitality and by your way of thinking, positive way of thinking.
Thank you, Doctor. Our last speaker is Dr. Hani Nakhli, who is currently a consultant physical therapist at Al Medina Specialist Hospital. He has held a variety of positions, which was the head of physical therapy and rehabilitation department at Al Medina Maternity and Children's Hospital. He's also a primary member of the Rehabilitation Education and Training Committee at the Ministry of Health. Dr. Nakhli received his Doctor of Philosophy in Rehabilitation Science from Loma Linda University. Also, he has his DPT from the same university. Also, he has the master's degree in physical therapy. And he will present for us today studying the impact of body posture and mental workload on office workers' health to prevent injury and disability. Welcome, Dr. Hani.
Assalamu alaikum. Good afternoon, everyone. I'm going to talk about my study today. It's in regards to the impacts of body posture and mental workload on office workers' health. It's a disability prevention approach. Just introducing some recent data. It's been shown that increasing rates of musculoskeletal disorders amongst the working community has been increasing. What types of disorders are we talking about? Mainly spinal disorders, lower back, neck, and there's also some other disorders like carpal tunnel syndrome. Also, psychological stress has been accounted for as a type of working disorder. These health-related complications are considered to be among leading causes for disability within the modern workplace and would normally begin with discomfort and pain. Dr. Ahmed talked about different definitions of disability, so we won't go through that. Our two main parts of the study is regarding to proper ergonomics and physical therapy. When we're talking about ergonomics, it's the science of dealing with the space, the workspace with the workers. So what does it do? It seeks to prevent such deficiencies that we just mentioned, along with their associated healthcare costs by studying and improving the relationship between the workers and their workspace. Physical therapy, which we can think of as the second line of defense. What do we do as physical therapists? We seek to reduce and fix these deficiencies by treating the associated pains that occur from not sitting properly or not proper ergonomics. So together, both ergonomics and physical therapy have been found to prevent injuries and subsequently disabilities, and to increase productivity, improve health, and raise job satisfaction. The objective of our study was twofold. First of all, to study and minimize office work-related pain from improper sitting. The second part was focused here in Saudi Arabia. There's not enough studies in regards to this part or in regards to this aspect, so we wanted to focus on Saudi Arabian workers. We used two different methods to gain our data. First of all, we used a questionnaire with 30 questions, which was submitted electronically. It was divided into 3 sections. Section 1, we collected the required data on occupational and demographic variables, gender, age, height, weight, and other related issues to the occupation that they work at. So how many hours they sit, and also related to exercise. The second part was designed to identify the symptoms that they were facing in regards to pain and all that. And the third part was related to their sitting ergonomics, if they were sitting properly, if they're able to adjust their seats, also in regards to some mental issues. The second part of the study, the second method that we used, was a randomized crossover trial where we had subjects go through 2 different trials. A first trial was a sitting trial where the subjects were sitting in their normal postures. We took the vital signs, blood pressure and heart rates, and after giving them a brief presentation regarding proper sitting positions, we also took their vital signs afterwards. The second part, which was on a second day, mental workloads. So also the individuals attended to work. After taking their vital signs, their superiors gave them extra workload. And we also measured their vital signs afterwards. These are some demographics regarding to the crossover trial and also regarding to the survey. We had over 1,000 subjects. Some were excluded because there were some key questions that they didn't answer, so they were excluded. And we came up to 986 subjects. The results. This is what the main focus of the study all comes up to. 74%, what we found out was 74% have ergonomically inconvenient workstations. What we mean by that is that they can't adjust, for example, their seat heights, their seat depths, their screens, so that was combined and we took a percentage. What that led to is that some were over 75% or 77% experienced some sort of musculoskeletal pain, where actually over 50% experienced 2 types of pains or more. The sad thing about what we found out was only 30% were referred to physical therapy. So they're having musculoskeletal pains, they're either not going to see their physicians or they're going to see their physicians, but they're not being referred properly. Another sad finding was from those 30% that were referred to physical therapy, less than half of them reported benefiting from physical therapy, which is, we didn't go into too much detail with that, but that's one of the studies that we will go in afterwards. But mainly it's because of their ergonomically misplaced workstations or because of they're not continuing their sessions. Also, what we found out was over 50% sit for more than 6 hours per day, and more than 70% exercise less than the standard. Finally, regarding cognitive or mental issues, only 22% were satisfied with their jobs or their work environment. So approximately 78% were neither satisfied or dissatisfied, or they were not satisfied. In regards to the pains themselves, the highest was low back pain, over 40%. Neck pain was 35%. After that was shoulder pain, and then we had scapular and thoracic region pain, which was approximately 20%. In regards to the correlations or relationships that we measured or that we made from our data in regards to their ergonomics or their sitting postures. So increased sitting hours was related with increased pains. It was significantly correlated with neck pain if you're sitting more than 6 hours, significantly correlated with shoulder pain, and sitting less than 6 hours was significantly correlated with not having pain at all. Also, in regards to the ergonomics or the sitting postures of the workstation, the 4 that we mentioned were highly correlated with some of the ergonomically missed postures. For example, if your feet were not fully supported, it was causing neck pain, back pain, and shoulder and scapular pain. What I mentioned here, the numbers that I put, the p-values was for the lowest significance, and then it goes higher. So for example, if the feet were not fully supported, the p-value was 0.005 or less. Also, sitting without pressure on the back of the knees. So if there is pressure on the back of the knees, it was causing increased pains. Keyboard and mouse at elbow height. So if they were not at the elbow height, it was increasing, it was causing pains. The least correlation was 0.041, and then it goes higher, 0.026 or 0.014. Also, in regards to your wrist and upper arms relaxed or not, and finally taking regular eye breaks. This is just a quick example of some of the right postures and wrong postures when we're talking about your knees having space between the seat and if they were having pressure or not. So the middle one is the right position and the other sides are not. So if your knees are too highly supported with the seat, then you're sitting in the wrong position. Also, in regards to armrest, if your arm is rested ideally or not, it's causing some shoulder pains and all that. We talked about vision. So if you're not taking too much eye breaks, it's causing spinal pains and different shoulder pains. So there's a 20-20 rule that ergonomic people usually study. Every 20 minutes, you need to look at something that's 20 meters away for 20 seconds. That way, you're moving your neck, you're moving your upper body, and you're decreasing related pains. Results regarding the trials, it was found that the average heart rate and blood pressure decreased after sitting properly, and the average heart rate and blood pressure increased after increasing your workload. The interesting finding in these results is the sitting posture was done on the day before the mental workload. There was 2 days difference between them. So after the individuals were sat in the right posture, they benefited from the presentation. On the second day or the day after, when we measured their heart rates and pressure, it was pretty low compared to the 98.6 before that. So they were benefiting from sitting postures. literature review, and related data. A recent study carried out in KSA, it was published in 2018, stated that there is not enough knowledge and awareness regarding physical therapy, not only at the patient's level, but also at the physician's level. So physicians are not referring enough patients to physical therapists. I personally have experienced a lot of patients with chronic pains, neck pains, shoulder pains, back pains, that have never seen a physical therapist. So they've been having pains for 2, 3, 4 years. After seeing a physical therapy for 2, 3 sessions, they're improving. So that's one of the findings that they found. Also, pain symptoms are a major work-related health problem worldwide. This is a different study, where most common complaints focused on neck pain and low back pain. It's consistent with what we found. There's also missing work days and working compensations related to all these pains and musculoskeletal pains. Low back pain, even though was the dominant problem for the last couple of years, now neck pain and shoulder pain is increasing. Because of what? Because of extended office hours and improper sitting postures. Also, a recent study, this was also in Spine magazine 2018, among participants with acute low back pain, so we're not talking about chronic now, acute, prolonged sitting hours of more than 6 hours, and stress or depression triggered low back pain flare-ups, so it was increasing the pain. And physical therapy was actually a deterrent of these flare-ups. Suitable workstations and equipment designs is actually increasing your level of job satisfaction. And finally, this was also an interesting study. Individuals with chronic low back pain have a lower level and or an altered pattern of physical activity compared with matched controls. So moving around, sitting, standing, it was altered, or they're trying to not do their normal activities. In regards from a physical therapy or ergonomics point of view, why maintain a good posture and what are the effects of bad postures? So good posture, you're having your joints, ligaments, and muscles of the spine positioned optimally, so they are under minimal stress. You can do your activities of daily living more easier, compared with poor posture where you begin having joint restrictions, tight muscles, and decreased mobility. Some examples of sitting postures properly, feet on the floor, your back and arms properly relaxed and supported, in compared with not sitting properly. From the physical therapy point of view, when we're talking about patterns and muscle imbalances, when your muscle length is normal, you're going to have efficient mobility and efficient stability. Compared with shortened muscle, you're going to have inefficient mobility with proper stability. And elongated muscle is going to be the opposite. Also here, focus is on having rests every at least 30 to 40 minutes. So even though you're sitting in a right posture, you need to move around every 30 to 40 minutes just to relax your muscles and move around. Finally, estimates from the global burden of disease. This is a study done related to the estimates of 2010. These two studies were published in 2014. What they found out was, globally, low back pain was ranked as the greatest contributor to disability as measured by years lived with disability. Secondly, low back pain arising from ergonomic exposures at work is an important cause of this type of disability. Third, the results show that the prevalence and burden from low back pain is very high worldwide, and it's concluded that low back pain causes more global disability than any other condition. Regarding neck pain, also a study related to the estimates, out of the conditions studied at the global burden of disease, neck pain ranked the 4th highest in terms of disability as measured by years lived with disability. and it was concluded that neck pain is a common condition throughout the world that causes substantial disability and economic costs. Conclusion, like we said, ergonomics and physical therapy, 2 lines of defense. To begin with, ergonomics, if you're sitting properly, you should not worry about things. If your posture, you're sitting in the wrong posture, you should see a physical therapist to get better and avoid any type of disabilities. Thank you so much, and for further information, me and my colleague.
Thank you, Dr. Hani. I hope I am ergonomically right and sitting after that 2 hours. Thank you for the audience, and fortunately for the time and for the sake of time, our speaker, they are here, so you might come and ask them directly because we have to break before the next session. Thank you for everyone. Thank you for your listening. Thank you for your patience. Again, thank you for our distinguished speaker, and I wish that you enjoy it. See you again. Assalamu alaikum wa rahmatullah.